Of all potential complications related to vascular access devices, infection is the most common. Catheters can be patient lifelines or provide patients with devastating outcomes. Let's turn our attention once again to catheter-related infections.
Take another moment to contemplate these statements. The following is a letter from a woman whose family had 3 different family members with a healthcare-acquired infection within 1 year. Her son Josh had a skydiving accident with a fractured skull and femur from which he was recovering well until he acquired a nosocomial infection. Josh died from his infection.
Our son died in the hospital 7 days ago. He died from a bacterial infection he caught there as a result of his medical care while being treated for something else. It created so much pressure around his brain that it caused part of it to be pushed into a spinal column, leaving him a helpless, ventilator-dependent quadriplegic and ending his short but unforgettable life among us all. Dear CEO, I hope you read this letter to your team aloud. Tell your board that we do not want anything for the loss of our dear son, but a dramatic and effective plan for change that will make a difference for others who trust healthcare in general and your hospital specifically. We look to you to partner with us as patients and caregivers so we may be all safe and well, both now and in the future. Sincerely, Victoria Naham.
Vascular access-associated infections can occur in the tissues surrounding the vascular access device or in the patient's bloodstream. Microorganisms entering the catheter through improper technique can colonize the catheter as well as susceptible areas of the patient's body, leading to infection. Catheter-related bloodstream infections result in significant morbidity and, in some cases, mortality. CRBSIs carry significant costs to the healthcare system. Treatment of nosocomial central line-associated bloodstream infections will no longer be reimbursed by Medicare beginning October 1, 2008. Understanding factors responsible for catheter-related infections is crucial in prevention and treatment. Infection factors. Use of contaminated administration sets, solutions, or medications. Contamination of catheter needleless connector, catheter insertion technique, site of insertion, use of multiple lumen catheters, migration of organisms from insertion site, thrombosis, fibrin, biofilm, and catheter occlusions. Remember, disinfect the needleless connector or catheter hub for 15 seconds and let it air dry prior to every access with a sterile Luer lock device. After disinfection, use no touch. Make sure nothing comes in contact with the disinfected needleless connector or the sterile male Luer end. If contamination of the connector occurs, disinfect again for 15 seconds. If contamination of the male Luer end of the administration set occurs, discard the administration set and replace with a new one. This is a great example of evidence-based practice.
Zero infection rates for central line-associated bloodstream infections are attainable. Keeping patient vascular access functional and safe is our duty. It's a team approach, and the bedside clinician is the captain. A first step in excellent evidence-based practice for vascular access devices is assessment. Prior to using any infusion device, the clinician must not only know about the vascular access equipment involved, but must also perform a thorough assessment of the catheter site.
Take a moment to contemplate this question. At the beginning of each shift and with each use, the clinician should assess all vascular access devices for erythema, induration, edema or swelling, pain, discharge, and catheter migration. To measure external catheter length, leave the occlusion dressing in place. Use a patient-specific measuring tape. The measurement that staff nurses use may be 1 to 2 centimeters different than the measurement provided by the IV nurse, in part because the IV nurse will measure during the dressing change. A proper site assessment would include intact, clean, dry dressing at all times. Assure that catheters are properly secured to prevent dislodgement or damage. Assess catheter for patency and blood return. Avoid catheter rupture and embolus. Don't force. Contact an IV nurse with questions or problems. What do you know about measuring external catheter length?
Hi, Steve. Steve, can you show me how to measure the external part of this pick?
Sure, Joanne, and let's do a complete assessment of this line while we're at it.
Thank you.
I can see by the color and the labeling that this is a solo power pick, which has the valve at this end. It has no clamps, so it's a non-valved catheter. And this is labeled as the power injection port. To measure the external catheter length, you measure from the insertion point to where the catheter hub meets the suture wings. This length should be within 1 to 2 centimeters of the original insertion length, which is documented on the insertion record. The dressing is clean, dry, and intact, and there are no kinks or bends in the catheter. And now, Joanne, we need to assess the entire arm.
How do I do that? What am I looking for?
We want to look at the insertion site for any redness or swelling or any discharge there. And then we want to assess the entire arm. We want to feel the upper arm for any swelling or any induration of the vein. How does your arm feel?
Fine.
Good. Lastly, let's make sure the IV tubing is labeled. It should be changed regularly every 72 hours. Intermittent infusion set should be replaced every 24 hours. This set is outdated and it needs to be changed today. Needleless connectors are changed routinely every 72 hours. If you're transfusing blood or doing frequent blood draws, you want to change the catheter caps more frequently, up to once a day, but not more, as it's important to maintain a closed system to prevent line contamination.